TOG 2024, Issue 3. Gynecological Pathology and Assisted Reproductive Treatment. Can we increase the chances of successful treatment by optimizing the pelvis? The summary table, CPD and SBAs are at the end of video. Introduction. Pelvic pathologies such as fibroids, polyps, congenital uterine anomalies, intrauterine adhesions, hydrosalpinges, adenomyosis, endometriosis, and ovarian cysts may have a negative impact on fertility and success rates following assisted reproductive treatment. When pelvic pathologies are identified, appropriate counseling about the different management options should be provided so that individuals can make informed decisions about how they wish to proceed. Management options for each pathology are outlined below, and the evidence is summarized in Table 1. Fibroids. Although 20 to 40% of women of reproductive age have a symptomatic uterine fibroid, fibroids are present in only 5 to 10% of women undergoing assisted reproductive treatment. Studies have demonstrated an association between fibroids and infertility, but the underlying mechanism is unclear. Hypotheses including impaired endometrial receptivity, implantation, uterine contractility, and sperm transport have been proposed. Fibroids can be classified as submucous, intramural, or subserous according to their anatomic location. Figure 1. Figure 1. The FIGO classification for uterine fibroids. The scale of the effect that the fibroid may have on reproductive outcomes appears to be related to their proximity to the endometrium. Compared with women without fibroids, women with submucosal fibroids have significantly lower clinical pregnancy and live birth rates and significantly higher miscarriage rates. Conversely, subserosal fibroids appear to have no significant impact on reproductive outcomes. The effect of intramural fibroids is controversial. Some studies have suggested that intramural fibroids may be associated with reduced fertility even in the absence of any cavity distortion. This may or may not be related to the size of the fibroid. A recent Cochrane review comparing reproductive outcomes following myomectomy and conservative management, that is, no intervention, reported no differences in clinical pregnancy rates irrespective of the proximity of the fibroid to the endometrium. This finding needs to be viewed with caution as only one small, very low-quality study was incorporated. If myomectomy is performed, clinicians may advise delaying conception to reduce the risk of obstetric complications. There is, however, insufficient evidence to strongly support this practice. The risk of uterine rupture during pregnancy after myomectomy is approximately 3.4% and most often occurs in the third trimester prior to the onset of labor. The decision regarding timing of a subsequent pregnancy should take into consideration the surgical route, the location, number, and size of fibroids removed, whether the cavity is breached, female age, and ovarian reserve. If the latter two factors are an issue, but the extent of surgery has been considerable, oocytes can be retrieved and embryos cryopreserved some time before a pregnancy is considered. Several non-surgical treatments for fibroids have emerged over the last few decades, with medical therapies as well as radiological interventions being proposed. A systematic review comparing fertility outcomes after uterine artery embolization and myomectomy found that pregnancy rates were significantly higher, 78% versus 50%, and miscarriage rates significantly lower, 20% versus 60%, after myomectomy. Patients contemplating a pregnancy should be informed that the effects of UAE on future fertility and pregnancy are uncertain, and that early ovarian failure may occur. A desire for subsequent fertility is therefore a relative contraindication to UAE, and the procedure should only be considered in this situation after careful counseling by a gynecologist with a special interest in fertility. The Sonata system combines real-time intrauterine ultrasound guidance with targeted radiofrequency ablation. Treatment has been shown to significantly reduce fibroid volume, but studies excluded women who had not completed their families, so its role in this population is less well understood. Although uterine wall integrity is preserved after treatment and successful pregnancies have been reported, further evidence is required on how the technology may affect fertility and obstetric outcomes. Similarly, magnetic resonance high-intensity focused ultrasound, MR-HIFU, is a thermal ablation technique that enables non-invasive treatment of fibroids by selective tissue heating. Although it appears to have minimal impact on ovarian reserve and successful pregnancies have been reported, further evidence is required on how the technology may affect fertility and obstetric outcomes. Finally, oral gonadotrophin-releasing hormone GnRH antagonists represent a new alternative to the medical treatment of uterine fibroids. Drugs such as linzagalix and relugolix have been shown to significantly reduce uterine fibroid volume and associated heavy menstrual bleeding. However, limited evidence is available on the effect of oral GnRH antagonists on subsequent fertility and obstetric outcomes, and therefore more robust evidence is required before they can be recommended to this patient population. Endometrial polyps. Endometrial polyps may be associated with subfertility, implantation failure, and miscarriage. In women contemplating ART, the prevalence is approximately 8%. The number, location, and size of polyps varies, but the majority are isolated findings on the posterior wall and less than 15 millimeters. The sensitivity of transvaginal ultrasound for identifying polyps before the start of treatment is high. but it is less accurate once stimulation has started, as the resultant rise in estrogen levels causes the endometrium to thicken and potentially fold, which may give the illusion of a polyp. However, in women with a history of 2 or more failed ART cycles, there is evidence of a significant increase in pregnancy rates in women who were randomized to receive hysteroscopy, plus treatment of intrauterine pathology including polyps if identified, compared with those who did not undergo hysteroscopy. If a polyp is suspected during stimulation, the options include continuing with the cycle and embryo transfer as planned, or freezing all the embryos and transferring them once a hysteroscopy with or without polypectomy has been performed. There is no clear evidence to recommend one option over the other, hence the decision should be individualized, taking into consideration any previous history of recurrent implantation failure and/or pregnancy loss. Septate uterus. The exact incidence of congenital uterine anomalies is unknown and varies according to the studied population. They occur because of 1. Incomplete development of one or both Müllerian ducts, 2. Incomplete fusion of the ducts, or 3. Failure of regression of the midline septum that forms during unification of the 2 ducts. A septate uterus is the most common uterine anomaly and may affect as many as 1% of the female population. The septum may be partial, with defects ranging from small indentations or complete, where the septum reaches or indeed also affects the cervical canal. Renal agenesis is found in 25% of women with a septate uterus. A septate uterus can be accurately diagnosed using 3D ultrasound, which is less costly than MRI and less invasive than the combination of hysteroscopy and laparoscopy. Compared with women with other congenital uterine anomalies, women with a septate uterus have the worst obstetric outcomes, with a significantly increased risk of first and second trimester miscarriage and preterm labor resulting in a term live birth rate of only 30%. This is thought to occur as the septum provides a poor implantation milieu for a pregnancy. Increasingly, hysteroscopic metroplasty or hysteroscopic transcervical division of the uterine septum has gained traction. However, a recent randomized controlled trial incorporating 80 women with a septate uterus and a history of either subfertility, pregnancy loss, or preterm birth compared septal resection and conservative management and found no significant difference in live birth rates between the 2 groups, 31% versus 35%. Although the sample size was limited and recruitment was over a long period, these findings, combined with evidence from a previous international multi-center cohort study, do not reveal any improvement in reproductive outcomes, thereby questioning the rationale behind surgery. However, recent systematic reviews of primarily non-randomized studies have yielded conflicting results. Hence, in the absence of more robust evidence the efficacy and safety of surgical treatment, no conclusive clinical guidance can be drawn. Although the guidelines from the NICE predate the aforementioned randomized controlled trial and systematic reviews, their sentiment remains valid. They suggest that current evidence on the safety of hysteroscopic metroplasty of a uterine septum includes some serious but rare complications, and that for women with primary subfertility, the evidence on efficacy is inadequate. As such, they advise that the procedure should only be undertaken with special arrangements for clinical governance, consent, and audit or research. In women with a history of recurrent miscarriage, the evidence on efficacy is adequate to support the use of this procedure. If surgery is to be considered, a recent network meta-analysis suggests that hysteroscopic septoplasty with scissors is associated with higher subsequent pregnancy rates compared with resectoscope. Bicorporeal uterus. A bicorporeal uterus may be partial bicornuate uterus or complete uterus didelphys. Women with a partial bicorporeal uterus have a significantly increased risk of first and second trimester miscarriage and preterm labor and live birth rates of around 55%. Women with a complete bicorporeal uterus also have a significantly increased risk of preterm labor, but no increased risk of miscarriage, and the live birth rates associated with this type of anomaly are consequently very good at around 75%. Surgery, in the form of an abdominal metroplasty to unify or restore the shape of the uterus, is not generally advised unless there is a very poor obstetric history. A complete bicorporeal uterus with double cervix is rare and usually asymptomatic unless it is associated with vaginal anomalies, such as an obstructed hemivagina with ipsilateral renal agenesis or a longitudinal vaginal septum. In such instances, presentation would usually occur in adolescence or early adulthood owing to the pain caused from obstructed menstruation and/or difficulties during intercourse. Endometriosis often coexists in women with obstructive Müllerian anomalies, and around 70% of women with a complete bicorporeal uterus also have unilateral renal agenesis. Hemi-Uterus. A hemi-uterus or unicornuate uterus involves unilateral uterine development. The contralateral part is either incompletely formed or absent. There may or may not be a rudimentary, functional cavity, and if there is, it may or may not communicate with the hemi-uterus. Alternatively, there may be a non-functional contralateral uterine horn, or there may be complete aplasia of the contralateral part. Renal agenesis occurs in approximately 30% of women with a hemi-uterus. A hemi-uterus is usually asymptomatic unless there is a rudimentary horn with a functional endometrium on the contralateral side. This is clinically important as it increases the risk of complications such as hematocavity or an ectopic pregnancy in the rudimentary horn. Removal of a rudimentary, functional cavity is therefore always recommended, even if the horn is communicating. A hemi-uterus has smaller dimensions than a normal uterus, and this might affect success rates following ART. Furthermore, the risk of first or second trimester miscarriage is approximately 35% and of preterm labor is approximately 20%. Thus, the overall live birth rate for all conceptions is approximately 50%. Cervical weakness is a concern, as it is with other congenital uterine anomalies, and as such, serial monitoring of cervical length is recommended during pregnancy, and insertion of a cervical circlage is sometimes necessary. Intrauterine adhesions. Asherman syndrome is characterized by adhesion formation in the uterine cavity or cervical canal. A common risk factor is dilatation and curettage following a miscarriage, but any kind of intrauterine surgery could cause adhesion formation. Infection is also a risk factor. Intrauterine adhesions are associated with high rates of infertility and miscarriage, and they also exert a detrimental effect during pregnancy owing to abnormal placentation. Hysteroscopy is the most accurate way to diagnose adhesions, although ultrasound can identify them if severe. Hysteroscopy has the advantage of being able to offer a see and treat approach if suitable expertise and equipment are available. Saline sonography can also be used for diagnosis and treatment. Surgery has been the mainstay of treatment for symptomatic intrauterine adhesions, but there are no randomized controlled trials comparing this with expected management. Indeed, the very limited data there is regarding conservative management suggests resumption of menstruation occurs in up to 78% of women within 7 years of diagnosis, and pregnancy occurs in 45.5%. This is obviously not particularly pragmatic when women desire a pregnancy, and as such, hysteroscopic resection is often recommended. In women with only filmy adhesions, there are limited data regarding the benefit of surgery, but given that these adhesions are easily treated at the time of diagnostic hysteroscopy, it seems sensible to do so. In women with moderate or severe adhesions, the recurrence rate following standard surgery is high, approximately 60%. However, a recent network meta-analysis suggested that insertion of a copper intrauterine device together with an intrauterine balloon is the best choice to reduce this risk, and installation of anti-adhesive agents is associated with the highest subsequent pregnancy rates. Even if surgery is successful at dividing all the adhesions, this may not imply normal endometrial function, as endometrium damaged by fibrosis may not regenerate despite estrogen therapy. Other treatments, including the use of low-dose aspirin, vaginal sildenafil, pentoxifylline, and high-dose vitamin E have been advocated, but the studies are either too small or not in the context of Asherman syndrome. Hydrosalpinges. Hydrosalpinges describes a spectrum of pathology of distal tubal occlusion occurring as a consequence of tubal infection, most commonly caused by chlamydia trachomatis. Numerous studies have reported poor outcomes following ART in patients with a hydrosalpinges, although the exact mechanism by which it exerts its negative effect is not completely understood. In patients with a hydrosalpinges undergoing ART, implantation, clinical pregnancy, and live birth rates are reduced by half, and miscarriage rates are doubled compared with types of tubal factor infertility. The risk of an ectopic is also increased. Laparoscopic salpingectomy is recommended for hydrosalpinges as it effectively doubles clinical pregnancy rates compared with no surgery. Salpingectomy should be considered in all patients with a hydrosalpinges, regardless of its size or fluid accumulation, but the evidence is even stronger for those with ultrasound-visible hydrosalpinges. Although salpingectomy may compromise blood flow and innervation to the ovary, it does not significantly affect the response to controlled ovarian stimulation. A salpingotomy can be considered as an alternative to salpingectomy if the tubal mucosa is healthy and appropriate surgical expertise available. This is useful if the patient is keen to continue to try to conceive spontaneously or if ART is not a viable option. Where severe adhesions due to endometriosis, previous abdominal surgery, or pelvic infection, for example, make salpingectomy technically difficult, tubal occlusion can be considered. A Cochrane review, including 2 small randomized controlled trials, showed a benefit in clinical pregnancy rate compared with no intervention, but this was based on low-quality evidence. Although no longer available since the device was withdrawn from the UK market in 2017, hysteroscopic tubal occlusion using Escher had also been shown to be effective, albeit less so than salpingectomy. Other microinserts have been developed and hysteroscopic diathermy has been tested, but none have been evaluated in randomized controlled trials. An alternative approach is to drain the hydrosalpinges at the time of oocyte retrieval. This has been demonstrated to be more effective than no intervention but not as effective as salpingectomy, and the recurrence risk is high. This is also an option if the hydrosalpinges is only identified after the commencement of stimulation. Another option in that situation would be to freeze all the embryos and plan a frozen cycle once a salpingectomy, salpingotomy, or tubal occlusion has been undertaken. This decision should be individualized, taking into consideration, among other things, the quantity and quality of the embryos available and the suitability of the patient for surgery. Adenomyosis. Adenomyosis is a benign uterine disorder with unclear etiology. It may be asymptomatic or associated with pelvic pain and abnormal uterine bleeding. With increased awareness and advances in imaging, it is now being diagnosed more often and at a younger age than in the past. A recent meta-analysis suggests that the overall pooled prevalence of isolated adenomyosis in women with subfertility is 10%, but this increases in the presence of concurrent endometriosis and/or fibroids. Although various ultrasound features have been suggested to be associated with adenomyosis, Figure 2, it is not clear which criteria are most important, and as such, diagnosis can still be challenging. Figure 2. Ultrasonographic features suggestive of adenomyosis. In patients undergoing ART, adenomyosis is associated with reduced implantation, clinical pregnancy and live birth rates, and increased miscarriage rates. This may, however, only be the case in symptomatic women. In women undergoing a fresh ART cycle, prolonged downregulation with GnRH agonists does not appear to improve live birth rates in women with adenomyosis, but it may be beneficial in frozen cycles. Owing to limited data, uterine-sparing surgery for adenomyosis is not recommended in women who wish to preserve their fertility, and neither are alternative treatments such as HIFU, MRI-guided HIFU, or UAE. Endometriosis. The association between endometriosis and infertility is controversial, as it can be present in both fertile and infertile women. However, it tends to be both more prevalent, 13.5% versus 4%, and more severe in infertile women than women with proven fertility. Endometriosis has a wide variety of clinical presentations depending on the extent of the disease and the organs affected. The American Society for Reproductive Medicine have developed a staging system which categorizes the disease as minimal, stage 1, mild, stage 2, moderate, stage 3, and severe, stage 4, based on a point scoring system to quantify the endometriotic lesions. Figure 3. Figure 3. The American Society for Reproductive Medicine staging classification for endometriosis. Advanced endometriosis, stage 3 and 4 disease, often significantly distorts pelvic anatomy, and coital frequency may be reduced because of deep dyspareunia, neither of which aids spontaneous conception. It is unclear, however, why less advanced endometriosis, stage 1 and 2 disease, causes infertility when the pelvic anatomy is not usually affected. In women with stage 1 and 2 endometriosis, operative laparoscopy may improve fertility. However, in women with stage 3 and 4 disease, there is no compelling evidence that operative laparoscopy improves fertility, but it may still be required to manage symptoms in women that are trying to conceive. The Endometriosis Fertility Index, EFI, can be used to identify women who may benefit from an early recourse to ART after surgery. It combines factors from the patient's history and operative findings to generate a score, ranging from 0 to 10, Figure 4. The lower the score, the less likely a spontaneous conception is to occur following surgery. Figure 4. The Endometriosis Fertility Index. ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised, if there is male factor infertility, in case of a low EFI or if other treatments have failed. Compared with women undergoing ART with no endometriosis, women with stage 1 and 2 disease have lower fertilization rates but comparable clinical pregnancy and live birth rates, while women with stage 3 and 4 disease have significantly reduced implantation and clinical pregnancy rates and either a trend towards or significantly reduced live birth rates. In women with stage 1 or 2 endometriosis, the live birth rates following ART were similar to women without endometriosis, whether operated on prior to ART or not. If laparoscopy is performed, however, an operative procedure appears to result in higher implantation, clinical pregnancy, and live birth rates than a diagnostic procedure alone. Unfortunately, there are currently no randomized controlled trials evaluating the effect of surgery on fertility outcomes in women with deep endometriosis. However, observational studies in women with surgically treated stage 3 and 4 disease have reported lower clinical pregnancy and live birth rates compared to women without endometriosis. Several studies have evaluated whether using a GnRH agonist for downregulation is superior to an antagonist in women with endometriosis. Despite an earlier Cochrane review reporting more favorable outcomes following prolonged downregulation with a GnRH agonist prior to the start of controlled ovarian stimulation, an update in 2019 concluded that the effect of this was uncertain. Additionally, there is insufficient evidence to recommend prolonged administration of the combined oral contraceptive pill or progestogens as a pretreatment to ART to increase live birth rates in women with endometriosis. Endometriomas. Endometriomas are found in around 5% of women contemplating ART. They are associated with anatomical damage to the ovaries and fallopian tubes as well as formation of adhesions, all of which may impair fertility. They are also associated with lower follicle counts and a reduced response to controlled ovarian stimulation during ART. Oocyte retrieval may be challenging in the presence of an endometrioma, and formation of a pelvic abscess is not an uncommon complication. Ideally, the endometrioma should not be punctured during oocyte retrieval, and prophylactic antibiotics are generally advised intraoperatively irrespective of whether the cyst is obviously punctured. If the cyst is obviously punctured, it is good practice to wash the needle with culture media before continuing to aspirate the remaining follicles. Management options for endometriomas include conservative, medical, and surgical approaches, but there is no robust evidence to support one treatment over the others. Scoring systems to aid clinicians in the decision-making process have been suggested. Conservative management should certainly be the first-line option for endometriomas, especially those less than or equal to 3 centimeters, and while medical management can reduce the size of endometriomas by up to 57%, it will simultaneously suppress the ovaries, thereby delaying ART, without any proven benefit. Surgical excision prior to ART does not appear to improve outcomes, but it may be considered for larger endometriomas or to improve access to the ovaries. Caution is required, however, as any ovarian cystectomy may lead to damage of healthy ovarian tissue, which in turn can reduce ovarian reserve and success rates following ART. It would not be unreasonable to freeze eggs or embryos prior to ovarian cystectomy, given the negative impact of surgery. Dermoid cysts. Dermoid cysts are benign, generally slow-growing, often bilateral, germ cell tumors that arise from totipotent ovarian cells. They are the most common pathological cysts in premenopausal women. Only a few studies have looked at the effects of dermoid cysts on ovarian function and fertility, but none have shown a negative effect. Histological examination of the ovarian cortex surrounding dermoid cysts suggests that it is stretched but not damaged by the cyst, as the cortical tissue shows normal morphological patterns and a regular vascular network similar to that of the normal ovarian cortex. Furthermore, a retrospective study compared women with an intact dermoid cyst to those who underwent cystectomy, and there was no difference in AMH, AFC, implantation, clinical pregnancy, live birth, or miscarriage rates between the groups. While ovarian cystectomy may therefore be performed to alleviate symptoms or exclude malignancy, there is no evidence that it should be routinely recommended for women with dermoid cysts prior to commencement of ART. However, earlier intervention, when the cyst is small, may reduce the need for repeated surgery, bilateral procedures, and relatively large cystectomies, all of which can have an adverse effect on fertility. Table 1. A summary of evidence-based recommendations and good practice considerations regarding the management of different gynecological pathologies prior to assisted reproductive technology. Kindly pause to read. Kindly pause on each CPD or SBA question to read it.